Everyone. Hi, Dr. Muhammad, Dr. Zainab, Dr. Albert, everyone's here.
Hi.
Dr. Tariq
Everyone.
is about to board. I'm not sure. Every time he
Happy to
disappears
see
from the
you.
screen, I get worried that he boarded. Hi, good to see you all. And Dr. Vaini Gupta, everyone's here. And Dr. Farah.
Hello.
Hi.
Hi.
Hi, everyone.
Hello, how are you?
Fine, and you?
Fine, how are you?
Hi.
Nice to see
Hello.
you.
Yeah. Hi,
Happy
Parula.
Father's Day, by the way.
Hello.
It's Father's Day.
Yeah. Happy Father's
Hi
Day.
there. Can
Father's
hi
Day.
hi.
Fathers.
Can you hear me, everybody?
Nobody remember fathers, all the times mother, unfortunately.
It's always Mother's Day, right?
Yes,
Every day is Mother's Day.
No,
yeah.
not
day
really.
is
I'm
Mother's
just
Day.
kidding.
definitely yes.
So it's okay. You can have start Dr. Yasmin if that's okay with you.
Yeah, let me just, so Dr. Tariq is texting that he can't share his video. For some reason it's blocked.
No, he is joining
here?
from something.
Tutorial.
He's join-
Yeah, but he was actually, his video was on a little bit, yeah, there.
I'm here. I'm back.
Okay.
Can you hear
Yeah,
me?
well, for some reason, you're also called Dr. Albert Khouri for today, which
Okay.
We have two
I don't
Alberts.
mind.
You're the-
Albert is a good friend.
yeah, sorry, can we fix that, please?
An
Dr. Muhammad,
Albert
are we
squared
on-
presentation.
Yes.
Are you traveling? Are you traveling or something, Tarek?
Yes, I'm in the airport actually waiting to board. So
So we
as
better
I told
start
Zainab,
soon.
I actually delayed the plane so that I can catch up with you.
We wish that we
Thank
can
you.
do this. We wish.
Thank you, really appreciate it. Yeah.
My pleasure. My pleasure.
Okay,
Okay,
Dr. Yasmin, you want something?
Can I start?
Yes, please. Yes,
Okay.
the mic, the floor
So-
is yours, please.
Okay, thank you. So we are starting our second glaucoma session for this meeting. It's titled What I Wish I Had Done Differently. And I'm so happy to be joined by eminent speakers from all around the world who are not just experts in their fields, but are also brave enough to be presenting their regrets today, which is what this session is all about. And my moderator, Dr. Farah Al-Pujani, is also joining us. She's a professor at the Government Medical College of Chandigarh, India. So without further ado, because we have a lot to get down to, we will start by our first speaker, Dr. Tariq Sha'rawi. Dr. Tariq is the head of the glaucoma unit at Université de Genève. I hope I'm pronouncing this correctly.
Oh,
It's
perfectly well pronounced.
working on my French, and the founder and president of the International Society of Glaucoma Surgery. He's also the author of many glaucoma books, one of the main glaucoma books we all refer to. And he happens to spend his weekends now traveling around the world, spreading and sharing knowledge. And today he's joining us from Cairo International Hospital, and he's about to board. So we better
Cairo
start.
International Airport.
Sorry, it's Cairo International Airport. Yeah.
All right.
For
So
some reason.
may I start?
Yes, please do.
Okay, very good. So thank you very much for having me. It's a true pleasure. And it's a good opportunity actually to share with you one of a big regret. And I think it's applies to many of us. And I think the message should spread. So this is a case of a 50-year-old lady that I met about 18 years ago. She has a family history of glaucoma in the family. Her father actually was blind in both eyes, but I never had the opportunity to examine him. So I don't know what type of glaucoma he suffered from. But the patient herself came because she was terrified, and at a very early stage of actually, she hadn't developed glaucoma when I saw her, and but her angles were quite narrow. So, taking in consideration that she's a hypermetrope, and despite that the pressure was normal, and because she was absolutely terrified, from what happened to her father. And because I saw some synecdoche and some localized pigmentation in the trabeculum, I decided to do a bilateral iridotomy for her. She also had a degree of pupillary block that you could see with the UBM. So we did bilateral iridotomies and things stabilized for a couple of years. Then she came in for her regular checkup. And mind you, this is maybe 10, 12 years ago. She came for a regular checkup and we found that the pressure of the eye went up. So mid-20s. No, I mean, basically an ocular hypertension secondary to the narrow angle. So we decided to put her on medications. And again, she stabilized, pressures are fine, nothing happening. 3 months later, she comes with the pressure gone again up despite perfect compliance. And some degree of damage that you can see in the, at that time, an HRT and GDX, I guess. Yeah, that must have been 15 years ago. So we increased the medications. 3 months later, she comes with, again, high pressure despite being on 2 molecules. So I put her on 3 molecules at that time. And she started to develop a little bit of some field changes, but distinctly glaucomatous. So not a lot of fun. Pressure stabilized again. I saw her 3 months later. And again, the pressure was out of control. So I took the decision that I regret of operating her for her glaucomas. And as at that time, an express was in fad, absolutely fashionable, you know, we were supposed to put the snail in and reduce the complications after compared to trabeculectomy. So we did one eye and we put an express. On the same day, a couple of hours after the operation, I usually see my patients on the first post-operative a day, and the pressure went to 50 with severe shallowness of the anterior chamber, and no brainer, she developed a malignant glaucoma. Malignant glaucoma is very notorious and is usually very difficult to treat. But I must have done something right in my life because I put her on atropine, and 2-3 hours later, the malignant glaucoma attack broke. Pressure went back to normal. And slowly we weaned her off the atropine. The chamber remained deep, no development of malignant glaucoma again, but she stayed on, I think, 1 molecule up till then. I mean, started on 1 molecule to reduce the pressure, and I think down the natural follow-up that she had, she's still on 1 medication. She is very afraid to have any further surgeries. And I think the lesson is, or lessons are, implants can express if you don't have a very, very, very wide experience, that is an international experience. You better be cautious, because later on, after we reported this case of malignant glaucoma, we had a lot of people coming out and speaking about malignant glaucoma after expressing narrow angles. Lesson number 2, don't operate the glaucoma if you have a narrow angle. Go for lens extraction, and in some cases, even a clear lens extraction would be warranted. Third lesson, which is basically something that I go with, is reduce the number of combined procedures of phaco and a glaucoma procedure if needed, if possible, and always opt for phaco alone. And if this doesn't control the pressure, then you always have the chance of operating the glaucoma in a later stage. And with that, I look forward to comments from my esteemed colleagues.
Thank you very much, Dr. Tariq. Very important take-home messages in this case. And I think, yes, we do remember cases of times where used to do trabeculectomy. I think trabeculectomy is always fraught as well with complications in those angle closure eyes. Do you think, Dr. Tariq, that Express increases the chance of going into malignant glaucoma compared to TAP?
Yes, I'm pretty sure. I mean, we've done in the good old days a lot of trabeculectomies in narrow angle. It was not a smooth ride, but the incidence of malignant glaucomas after Express is incredible. And I compared our results with results from centers that are heavy users of Express at that time, all around Europe, in North America, as well as in Russia at that time. And the feedback that I got was quite similar to mine.
And you still
Which
use
Express
it
was
on
that?
peritoneal, the Express. Do you still use it in
Which one?
open angle or other cases?
No, totally
No.
abandoned. Maybe I have one in my operating theater for the odd case, but I don't think I have put one for the last maybe 3-4 years or so.
Very much, very important case to show. I'm not sure if you're staying to the end because we'll probably have more questions, but we'll have to go ahead with the next presentation. Dr. Sidi Mohammed Zuhairi, a founder of and president of the Moroccan Glaucoma Society and Moroccan Association Against Glaucoma. He's a board member of the French Glaucoma Society. Hi, Dr. Mohammed. Hope all is great.
Hi.
So we can see, yeah, we can see the presentation. You can go ahead.
Okay. So thank you for the invitation. Thank you, Mohammed Al Amri. Thank you, Yasmin Sayed, for this kind of invitation. My talk is about an unusual case of iris and consideration after deep sclerectomy. I should have done it otherwise. This is a case of a man who underwent non-penetrating glaucoma surgery in Europe for a open angle glaucoma, a severe open angle glaucoma. And I follow him up in Morocco for many months. And one day he came with an iris prolapse after receiving a accidental traumatism by the elbow of his son on his eye, with this iris prolapse, as you can see in this image from CT lamp. And on gonioscopy, we can see this incarceration, and we can see also some behind the iris, some ciliary processes. So I tried to reduce it by YAG, but I failed, and I came with it. I went with him to the operator room. Then I share with you the video for this surgery. I filled the interior chamber with viscoelastic and try to perform this desencarceration, which was really very easy, as you can see here. And after that, I just perform a needling, because I found that the blevis was a little bit flat, and when I tried to remove the viscoelastic, I was surprised to find a device was floating in the interior chamber. So I refilled the interior chamber with viscoelastic, and I enlarged the incision, the corneal incision, by a knife 2.2, and I tried to grasp it and to remove it out of the interior chamber with these forceps, as you can see here. Here we can see, well, I was found, this is a snopper and we can see in this photo how it's the surgery is performed after the dissection of this rectomy and the peeling of the inner wall of the Schlems canal. We perform an incision to introduce this device in the suprachoroidal space in order to improve the outflow and also to make open this space. Here I share with you the postoperative images on slit lamp and on gonioscopy, and we can see how it on gonioscopy how it's wide open this trabecular distal membrane window. Unfortunately, with a good pressure, but unfortunately, 1 month later, he comes again with that. And I decide to take him to the operating room, and again I refill the anterior chamber with the viscoelastic. I perform disencarceration, and I added a large surgical iridectomy with vitrectomy, as you can see here. Postoperatively, at day 1, as you can see, the pupil is round, the cornea is clear with a good iridectomy, and we can see on the gonioscopy how this iridectomy is in front of this window with this opening of trabecular distal membrane. This is images 1 month later. The bleb is good with intraocular pressure at 10 millimeter mercury, and I hope things are all right now with this case. So my messages could or should perform this surgical iridectomy systematically in cases of iris prolapse or not. From this case, I think it's definitely we have to perform this surgical iridectomy, or in cases of goniopuncture with if the angle is narrow, we can perform also iridoplasty. And the second messages, we have to know the report of the previous surgeries, and because now we can have patients with mixed surgery mixed with conventional surgeries, and really we will have to know these details about previous surgeries. And thank you for your attention. I thank Professor Sharawi.
You thank me for sending you all my tough cases back to Morocco.
This is a case who was benefited from the very good and nice surgery from Tarek Sarawi, and now the patient is very, very good as
I mean, when I get patients from Morocco, I always wonder why are they coming when they have you there. I mean, it's I don't turn them back, but if they send a message before coming to Geneva, I always say there's really no need to come to Geneva with you in Morocco, and I mean that sincerely.
Thank you so much.
Thank you very much for a very nice case, Dr. Mohammed. Very nicely managed. Any questions from the panel or audience? Okay, I think we move on to the next speaker, our dear Professor Dr. Albert Khouli, who's joining from New Jersey. He's the director of the Resident Education Program and the director of the Glaucoma Service in Rogers, New Jersey Medical School, and the author of many research articles. Dr. Albert, always good to see you.
Thank you, Dr. Yasmin. Thank you for including me on the program, and
Go ahead.
nice to see friends and now family officially. Tariq, you're Tariq Albert Sharawi Khouri. There you go. I have a picture of it on my phone now.
Before they change the name.
So let me just share my presentation. You can see the slides, right? Okay. So for me, I wanted to share not a single case. I thought about sharing a series of complications, things that we don't usually talk about or pay a lot of attention to, but that has caught my attention. So we looked into this about specifically pupil abnormalities after glaucoma tubes. Those are my disclosures. None of them are really relevant here. And the tubes are, as I don't need to tell you, you all know they're very commonly performed now. I mean, they're the go-to or almost primary surgery in a lot of countries. This is data from the US showing a downward trend with trabeculectomy and an increasing trend with tube surgeries. This is data from Australia as well, again showing a decline in trabs and an increase in the number of tubes that are performed annually over the past decade or so. Tubes and trabs have a lot of complications, and my colleagues just shared some of the complications with these surgeries. The trab versus tube study looked into this. You can see here early complications with tubes, mostly related to hypotony, choroidal effusions, and late complications mostly related to corneal pathology, specifically corneal edema, and a bunch of other complications. But you can see we rarely pay attention to the iris or the pupil specifically after these surgeries. And when you examine eyes that have had tube shunts, invariably you see some degree of iris abnormality or pupillary stretching in many patients. So we decided to look at what's going on with these patients, and specifically regarding pupil abnormalities. I had a group of medical students working with me. We collected data on 68 eyes that have had glaucoma drainage devices. We took pictures of the anterior segment with a portable slit lamp, and then we examined these images for pupil abnormalities. While doing that, we also gave patients a questionnaire on dysphotopsia, and we adopted that questionnaire from a paper by Dr. Spaeth at Wills. Then we collected a bunch of other data on these patients, including ocular diagnoses, medication use, other diagnoses in the eye, etc. And this is that questionnaire from for dysphotopsia. It's pretty simple. It asks whether patients have had any of the following symptoms in the past 7 days, and it's either a yes or a no response. Now, for our 68 patients, you can see here, half of them were older, between 60 and 80. The majority had pretty good vision. The majority had primary open-angle glaucoma and have had OMID tube shunts. But they also, as is common with glaucoma tubes, they were on multiple medications, on 2 to 3 meds in about half of the patients, and which led clearly to ocular surface disease and dry eye symptoms in about half of the patients. So of the 68 eyes that we looked into, more than a third had an abnormal iris with a peaked pupil which varied in severity from very mild peaking towards where the tube goes into the anterior chamber to more significant peaking. And it was not surprising that the majority of the patients had reported dysphotopsia symptoms that ranged from blurring to shadowing, glare, and ghost images. Now, the patients that had the dysphotopsia, we wanted to look specifically at those because it's not just about the iris being peaked or distorted, although some patients do notice that, especially if they have unilateral glaucoma and they're younger. So we wanted to specifically look at that group of patients, and 3/4 of the patients basically with a peaked pupil reported having dysphotopsia. And the majority of those patients had good vision and had dry eye disease. So the combination, it seems, of being on multiple medications, having dry eye, and having a peaked pupil seems to cause the most symptoms. So what did we learn from this project? And it's an ongoing project, so we continue to do some more work on this. We learned that about 1/3 of the patients have iris abnormalities and pupil peaking, that the majority of those patients, 3/4, had dysphotopsia. And it was obviously multifactorial, but mostly in patients with multiple medications, a dry eye, distorted pupil, and good acuity. And what I've changed in my practice after learning from this project is when consenting patients for tube shunts, I talk to them that there is this chance, 1 in 3, that their pupil could be abnormal afterwards, and that could contribute to some dysphotopsia symptoms post-operatively. So I think having that discussion, we talk to patients about many complications of tube shunts, the big ones: low pressure, high pressure, infection, bleeding, repeat surgery, exposure, but we do not really touch on the pupil abnormality, and I think it's important that we do. So thank you for having me with you this morning. Thank you.
Thank you very much, Dr. Albert. I will definitely include that in the counseling of patients from now on. Remember you in every case of tube surgery. And do you think it's very important point to look at, really, very novel, and it's quite common. So do you think there are steps that can help avoid that now that you recognize that it happens, this distortion? Are you trying extra steps to try to minimize the risk of pupil distortion?
Yeah, so what we haven't, I don't think the chances of this complication is equal among all patients. I think like uveitic, neovascular eyes are more prone than POAG eyes. But I think as glaucoma doctors, we all struggle with this single step where if you're too anterior, you're close to the endothelium and you're worried about the cornea. If you're too posterior, you're like chafing the iris root. And I think that's what causes partly this problem. And I think until we figure out a more precise way of entering the anterior chamber with that needle, these things are going to continue to happen. I think that's where the money is with this, avoiding this complication. Yeah.
Thank you very much. And now we will move on to our next speaker, dear friend, Dr. Zeynep Aktas, Professor of Ophthalmology, who is joining us from Ankara. And Zeynep had her glaucoma fellowship at the University of Wisconsin in the US and is currently working at Attilum University School of Medicine. Zeynep?
Hello.
Hello.
Sorry.
So Zeynep's laptop crashed yesterday, and so this is her new.
Can you see my?
Yeah, but they're tiny icons. If you could just press.
Tiny icons?
Oh, no, actually, no. It's a screenshot. So if you can just find the presentation.
Sorry. Okay, let's say I can find my desktop. Sorry.
So any questions for the previous talks from the audience or panel? Until the presentation is, okay, there you go. You almost, okay, there you go.
Now can you see?
Yeah.
Now can you see it again?
Yes, we
Okay,
can.
now, it's great to be here and see you all, guys. So thanks again for the invite. It's a great pleasure for me. So this is what I brought here. It's not a catastrophe, but it's a good case. So this is a 10-year-old girl with primary congenital glaucoma. She had a history of bilateral trabeculotomy, and then a couple of years after that, a tube surgery, Ahmet glaucoma valve surgery by me, and a visual acuities were 0.2 on the right and 0.4, and there were myopia and astigmatism and due to HAP stress and of course the buphtalmus, and IOP was 33 in the right and normal in the left eye, despite maximum medical treatment. So pachymetries were a little bit thick, and cup disc ratios are quite high in the right eye. So you see here the anterior-segment photographs of the girl. There's a tube here, and there's a pupillar peaking here, by the way. And I checked the gonio, the angles with gonioscopy, and as you see here, there are some synechias in the superior quadrant. This is inferior quadrant. There are some pigments, and it's quite open. And this is temporal. These are dysgenic angles. You know, in the nasal part, you see some peripheral anterior synechias together with pigments, but on the temporal side, you see the high iris insertion and no PIS at all. So at this point, I just thought that it's worth moving on to, it's worth trying to another angle surgery instead of putting in a second tube. So this is the surgery. You see here the tube. And I'm doing here percentesis and also inferior clear corneal incision and check on the angle perioperatively. You see here, this is typical angle of cases with primary congenital glaucoma, high iris insertion, and I do a goniotomy here, and I'm in the Schlem's canal. I try to insert the 5-4 ProLens suture here. So it's actually in the canal, so I'm trying to see where it is, and it's right behind the iris, actually, iris process, but it's hard to pull and hard to tear up the trabecular meshwork here in this case. This sometimes happens in patients with primary congenital glaucoma, even in cases you do get or angle surgery as a primary procedure, but more often, according to my observations, more often happens in patients with after a couple of surgeries. So I decided to move on goniotomy with MVR blade. So did a couple of quadrants here. This is temporal quadrant. And you see here I'm performing goniotomy with MVR blades, and this is nasal quadrant. I'm trying, and my assistant is trying to rotating the eye. So we performed goniotomy again in the rest of the angle as much as possible, and then you see here the irrigation aspiration step. Okay, so let's see what's happened. So first day I soft, and there was a minimal mild hyphema. And this is 7th day. So in the first couple of days, I generally switched to topical non-steroidal anti-inflammatory drops. In 7 days, there were so many red cells and also mild corneal edema, a little bit inflammation. So I switched to lotoprednol, and also IOP was 23 with one medication. So I switched to maximum treatment in this case. So after a couple of days, on 12th day, IOP was 16 with maximum treatment there, and I was relatively quiet with no cells and no edema. And then I switched again to topical non-steroidal anti-inflammatory drops. And this is first month. It's very early. First month checkup of the patient with one medication. It was 15 millimeters mercury with one medication. It's not that bad. So, okay, what would I do in this case? What would I have done here in this case if I'd seen this patient today? So let's remember what should we do in cases that our flow chart in patients with primary congenital glaucoma. We generally start with angle surgery depending on the patient's corneal clarity, or of course our surgical preference and experience. We do goniotomy and trabeculotomy, and then if it fails, or if the first surgery is not the circumferential one, we move on to again angle surgery. to make it circumferential. And then if it fails, we can do filtering surgeries or tubes or sometimes diode lasers. So as we know, circumferential trabeculotomy results and outcomes are better compared to conventional angle surgeries, as shown by so many papers in the literature. And this is our paper also supporting that in patients with primary congenital glaucoma, known as onset primary congenital glaucoma. And this is our recent paper showing the gut outcomes in patients with primary congenital glaucoma. It was a study done in 22 eyes of 14 patients, and the mean IOP reduction was almost 60%. You see here the IOP values throughout the 2-year follow-up, and also on the right-hand side you see the number of glaucoma medications and reduction, percentage of reduction, and also the most common complication was the microhyphema, as you expected. So the complete success here in these cases was, which means without medication, was 63%. On the other hand, qualified success was 95%. So this endosurgery as a second surgery or after a couple of surgeries, intraocular surgeries, can be done, of course. I think our surgical decision was the right one here in this case at this point. But in some patients, it might be easy. In some patients, it might not be easy. This is another case. After two filtering surgeries, instead of putting the tube in, we did angle surgery in the rest of the angle. As you see here, the surgery was relatively smooth here in this case, as you see. So it's doable as a second procedure for sure.
Zena, we can't hear you for some reason. Can you hear us? There's no voice.
Can you hear us, Doctora? Doctora Yasmin, can you hear me?
Yeah, I can hear you, but can you hear Dr. Zena?
No, we cannot. No.
No.
I think we can see only the conclusion anyway.
Okay, so Zena, I'm sorry, but your voice disappeared in the end at the conclusion. We still can't hear you. You're unmuted, and we can't hear the.
Okay, there's something happened. I have no idea. Sorry.
Okay, yeah, it's fine. Yeah, but we got it because the conclusion was written down. Very nice case to present, and you know how much of an avid gatter I am.
So you didn't hear? So you didn't hear?
I didn't hear the conclusion, just the conclusion part. Okay. So, but we saw it written. So yeah, you conveyed.
I would have done angle surgery as first place in this case.
Okay. Great, very nice, very nice. And I have a question for you. So, what the patient she had or he had a trabeculotomy, you said, was it the circumferential one, the primary one?
No.
Or
no.
A regular superior?
It was just a conventional with metal harms trabeculotomy, because in these days I wasn't experienced that much to do circumferential surgery, so it was conventional.
Yeah, I think at some point everyone was doing conventional, and that's a few years back, and then more and more people are switching to circumferential incisions.
This is what I do.
And when you are incising an angle that was incised previously ab internal, what are the signs that this is working or that you're in the correct plane? Because usually it's a bit shaggy, the angle, when it's been incised properly before.
So are you talking about this patient?
Yeah, about operating on the angle from an ab internal approach when it's been incised before, because it's quite difficult.
Yeah.
You know, you showed it very nice.
It's quite difficult. In some patients, Yeah, it's in some patients it's easy, as I showed you, but in some patients there might be some synechias, maybe in the postoperative period after tube surgery, maybe the AC was shallow. I don't remember. There are some PIS, and in some patients also there maybe you experience that there might be some tissue resistance. And you cannot overcome it with only with suture. So this is what I felt in this case. So that's why I switched to goniotomy, classical goniotomy with the MER blade.
Yeah, very often needs to be completed. Actually, we had a study, a case series, a small case series published a couple of months ago on GAT in failed surgeries, glaucoma surgeries in children, and the results are really great. So it's worth attempting, giving the chance for the angle one last time before resorting to more invasive surgeries. I totally support that. Anyone has a question? Dr. Vani Gupta, I see you're unmuted. Yeah.
Yeah, I have a question, Zainab. I mean, it was a very interesting case that you presented, but the results that you showed of a success of absolute success rates of 65%, I mean, are they for primary GAT or are these results for a secondary GAT that you're doing?
No, it's primary GAT procedure, of course.
Yeah. Yeah, I mean, I'm only skeptical because I mean, if the patients have to take medicines, you know, with these kids, it becomes very difficult on a long term, you know, the rest of their lives, they are on medication. So, I mean, I would like to have a higher success rates. I don't know. I mean, what does Yasmin think about the fact that, you know, you need 95% success rates with the surgery you do in a child as a primary procedure?
95% with medication or without medication?
Without medication.
Without medication. I don't know. It's interesting. There are so many different results from different areas, as you know. There are so many factors. It's multifactorial, maybe genetics, maybe geography. I always wonder that.
Yeah, so we always do a combined trabeculectomy with trabeculotomy, you know, and that doesn't really work so well in eyes which are very large corneal diameters. Children who present late, you know, for some reason, it just doesn't work in these cases. And that subgroup apart, then there is another subgroup of children with other congenital malformations where, again, the GAT doesn't work at all. So it actually works in a very small subset of children who have, you know, a non-severe kind of congenital glaucoma. So when you talking of congenital glaucomas in general, I mean, GAT actually works in a very small subset, and you cannot use it for every child, actually. I mean, we see a gamut.
I totally agree.
Yeah.
My clinical observation is it really works in early presented isolated trabecular dysgenesis.
True.
Yeah, you can have single digit IOPs without medication in these cases. I totally agree with you.
Yeah.
Okay, Dr. Bani, I think we move on to your talk. Dr. Bani, who's a professor of ophthalmology, joining us from New Delhi. He's the head of glaucoma service at Rajendra Prasad Center, and he's also the president of the Indian Pediatric Glaucoma Society.
Yeah, thanks, Zainab. I'm very happy to be joining this meeting. And what I'm going to present here is something extremely rare, something which is heartrending, something which actually shook me to the core. And so I'm going to tell you the story of this young girl who came to us. She was a 12-year-old girl with Marfan syndrome, and she presented with very poor vision in both the eyes. And when she was first seen by our retina colleagues, she had already lost her right eye to a total closed funnel retinal detachment. And even in the left eye, she had a total retinal detachment and a posteriorly dislocated lens. So our retinal colleagues went ahead, they did an encirclage with lensectomy and a vitreoretinal surgery for her only seeing eye, which was her left eye. And unfortunately, she again developed an inferior retinal detachment, and they had to again redo the surgery, and they put a lot of silicone oil in the eye. Unfortunately, the child, after a few months, developed a secondary glaucoma, which was just intractable. So we asked our retinal colleagues if they wanted to remove the silicone oil, but they refused. They said that the risk of redetachment is very high, and they just didn't want to remove the silicone oil. So when the child was referred to us, she had no light perception in the right eye, and the left eye, she had a good vision of 624, but her intraocular pressure was really high. despite maximum tolerable medical therapy. At that time, her cup disc ratio was about only 0.7. Given the fact that she's had a vitreoretinal surgery, she's aphakic, I don't think we could have done a filtering surgery, and doing cyclodiode or cyclophotocoagulation again was not a very good option in a child. And so we took her up for an M glaucoma valve implantation, which we did. Unfortunately, after a month or so, she had a very severe encapsulation of her bleb. Her intraocular pressure rose again to 34 millimeters of mercury, and she started showing a progression of her cup disc ratio. So at that time, I decided, now that the bleb of the AGV is undergoing encapsulation, why shouldn't I try doing a needling to remove that encapsulation? And I went ahead with a needle. You can see that there is some amount of emulsified oil still in the anterior chamber. You can see the anterior, there's a tube in the anterior chamber. And as we proceeded with the needling, you can see that the bleb was extremely high. It was quite a posterior bleb, very difficult to reach, but we still managed to go ahead and get needling done. I finished the needling, and as soon as I looked at the anterior chamber, I found that there was no tube in the anterior chamber any longer. And to my surprise, I couldn't find the tube. And what happened, I really couldn't understand. So the next day when I saw the child again, there was no tube in the anterior chamber. So was it that during the needling procedure, I had accidentally, cut off that tube from its insertion into the plate, and, it had fallen somewhere in the anterior chamber, either in the angle. We did an ASOCT for the child to look for that tube in the angle, but we couldn't see the tube there. We did an ultrasound biomicroscopy. Maybe it was lying somewhere in the posterior chamber, somewhere behind the iris. We couldn't find the tube there also. We did an ultrasound. Maybe the tube had just fallen off, cut and fallen off into the posterior chamber, but there was no tube there. And the intraocular pressure again rose because there was no filtration happening, and the IOP again rose. So this was a case of a missing tube. I don't know if anyone else has ever experienced this case, such a case where after the needling of an AGV bleb, the tube just kind of disappears. And at that point, I wish I had just not performed this needling, but then I didn't have any other options. So ultimately, we had to take up the child again under anesthesia. We had to explore what had happened. And so I'm going to show you what had happened. So I had to cut open the entire area because, of course, there was a bleb. So there must have been a plate lying there, but obviously the tube was not there. So I needed to find where the tube was. And this is what we had to do. We had to open up the whole conjunctiva. We could find some ends of the plate. So obviously the plate was there. It was embellished in a very thick capsule, and we could see the end of the plate. So this was the plate which was there. But look what had happened. As I started pulling out the plate, I found that the whole plate with the tube had rotated posteriorly. The tube which was lying in the anterior part had completely rotated posteriorly, and was now kind of had to be reimplanted back to its position. So this is what I did. And what I interestingly found, that the entire plate and the tube was totally filled with silicone oil. It was as if they had been soaked in silicone oil. And this was probably because the silicone oil was all coming out from the tube, from the anterior chamber, and into the bleb. And therefore, this whole tube and plate was soaked with silicone oil. Anyway, I repositioned the tube back into the anterior chamber because we had to have some filtration and reduce the intraocular pressure. So, so I don't know if any of you have ever noticed this kind of rotation of the whole plate and the tube that happens after needling of a bleb, but of an AGV bleb. But to my surprise, I mean, I have never ever in my entire career seen such a rare complication, and I believe it has got something to do with the silicone oil. Probably my needling, led to breaking of some sutures. Probably it led to the whole plate being extremely slippery in that silicone oil filled bleb, and it just kind of rotated posteriorly. Maybe it was the silicone oil itself which was the reason why this whole thing happened, and therefore I just advise that, if you're doing needling of these blebs, you have to be a little careful. Keep watching the anterior chamber. I mean, I'm sure it can happen with someone else, and probably this could be more common in eyes which have had vitreoretinal surgery with silicone oil, because for some reason the silicone oil does get into the bleb, and it can make this whole bleb with the AGV extremely slippery, and this complication could easily be avoided. Thank you.
Thank you very much, Dr. Vani. What an interesting case. Now, I myself have seen a lot of bad coincidence with accidents with the tubes, but never this one. Full rotation, 180 degrees. Yeah, that's something to report. Any questions or comments from the panel?
I had one case, Dr. Vinay. It was not similar to yours. It wasn't a Marfan. It was a highly myopic eye in a child that had an Ahmed, and I did the Ahmed surgery. The sclera is so thin, your bites, are as thick as you can safely feel you can put them. And then that child came back. The mom noticed a huge bleb, and what had happened was the backside of the Ahmed literally did a 180 degree and was now laying to the front. So it was still attached at the two scleral bites, but it had flipped upside down. And I've never seen anything like this. I took the patient to the OR, and I dissected, and I placed it back, and I placed the posterior suture to prevent it from coming forward. But I can see how in a myopic eye where the front sutures can be flimsy, with the oil on top, how if the needle had engaged the reservoir at some point, it could have dislocated it entirely. Very interesting case. It will stick with us.
Yeah. Thanks.
Okay, so now let me share my final talk for this session. Okay, so I'll keep it short so we have some more time for discussion in the end with all the speakers. So this is about what I wish I'd always done for post-pars plana vitrectomy glaucoma. The incidence of ocular hypertension plus minus glaucoma following a vitrectomy is around 2% in 6 months and jumps up to more than half the cases by the 8th month. And many of these cases require surgery. The usual paradigm is to start with a glaucoma drainage device, which is really a great choice. And cyclodestructive procedures are an option when a tube is not possible or the visual prognosis is bad. Non-penetrating glaucoma surgery is also a good option because it doesn't really rely on the conjunctival health. TRABs, well, maybe not for the silicone eyes, but if you have a good conjunctiva in a patient that was air-filled, you can attempt. I do not really do that, but it's not definitely a big no. But the problem with glaucoma drainage devices, in addition to what Dr. Vani and Dr. today, is that there are so many complications and risks, and the success rate is not even very high after vitrectomy because of all the scarring that lies there from the buccal or band or even the sclerotomies themselves. So this is, for instance, a patient that I was doing a tube for, and he never mentioned anything about having a band, just a vitrectomy, and then you're faced with a situation where you either have to shorten your Beervold or replace the tube elsewhere. So all filtering procedures indeed have their own risks, especially of the bleb itself in terms of hypotony or the lifelong risk of infection. And with the introduction of the GAT, which has been shifting to for most of my cases, to be honest, in the last 3 years, GAT is a procedure that allows us to incise the whole inner wall of the Schlemm's canal to reduce the resistance to outflow. And at this point in 2020, I was experimenting with GAT in different types of glaucomas, and 2 studies came out, one on GAT in post-vitrectomy eyes by Kwan and co-workers, and the other by Zainab Actis and co-workers, again in vitrectomy after silicone oil removal. So the first study was a retrospective one that looked at 8 eyes, of which 5 were actually silicone eyes, which is a scenario we all find difficult when the VR surgeon is just deferring the decision to remove the silicone. The pressure is high, and you know that if you tackle the pressure at this point and then they remove the silicone, the pressure may come down to hypotony. So they've done GAT in those eyes, and the pressure dropped from 52 down to 13 on significantly number of medications. In the second study, it was a retrospective case series again on 15 eyes, where the pressure dropped from 31, almost halved at 15. The qualified success, that is a pressure of 21 or less on medications, was 93%, and amazingly around a quarter of the patients were off medications at the final follow-up. So in light of these and my enthusiasm for GAT, which is still there, I decided to do GAT for a child that was 13 years old back then. He had congenital cataract surgery when he was a baby, then developed a detachment, had pars plana vitrectomy, then silicone oil removal. And I was following him up, but he had compliance issues. His pressure was 21 on 2 meds. He had a cuffing of 0.6. And actually, when I went in, I wasn't aiming to control the pressure as much as to just patch. There's an area down here in the figure that is thinned out from the sclerostomy. So my main intention was to cover this with a patch. But I thought, if we're operating anyway, why not just discuss with him having GAT and minimally invasive glaucoma surgery as well. I didn't feel like doing a tube at this point because I could have just added more meds, although, again, compliance was an issue. So I decided to go for a GAT in addition to the sclera patch for the thinned out area. And as you can see here, although he had silicone oil removal, there are always these remnants that no one can completely empty. And it is known that silicone does cause scarring at the level of the Schlemm's canal and sometimes PAS. Luckily, this boy did not have synechia in the angle, but I went ahead with the GAT procedure, and luckily I managed to do it circumferentially. There was no scarring at the level of the Schlemm's canal that stopped me. At some point, the proline suture stopped, and I had to retrieve it with a cut down, but eventually I managed to do a 360-degree incision. And then I examined the angle, and surprisingly, it was so full. I'm not sure if it shows here with the resolution, full of tiny silicone bubbles that was occluding the whole human. And when I cleared it with the bimanual, it was completely clear in the end. Very gratifying to see that. And eventually, I've been seeing this boy for 3 years now. His pressure has come down to less than 15 at all post-operative follow-ups with no medications. So this is not the usual, of course, success rate. I was lucky with this boy, and he was lucky. I've done since then around 10 cases of pars plana vitrectomy eyes, and where I did GAT for them. This is another case with high pressure, again, now controlled on medications. But I would say that the success rate is around the range of 50% of getting away from doing a more invasive procedure. Of course, I counsel my patients now whenever I get a patient that is suitable for a GAT post-pars plana vitrectomy. They have minimal PAS, open angles. Even if the pressure is very high, I did not feel that this is affecting the final outcome. I'll definitely collect the data from the series I did. But for the time being, I offer angle surgery as a minimally invasive option for patients with post-pars plana vitrectomy. Of course, it's important to counsel these patients. The success rate is not amazing, but then again, you're saving those eyes from all the risks inherent to filtering procedures or cytodestructive procedures. Thank you. Okay, so I think we have 2 more minutes to end the session. Time for a question or two from the audience or the panelists.
Have you tried limited diode laser cyclophotocoagulation in such patients which are nearly refractory despite several procedures for glaucoma surgery?
Yes, I do, for sure. But especially cases that are not suitable for GAT, I would go for the subthreshold diodes, which I really like, and it's quite safe. And I use it as a backup even before going to more invasive tubes now, if the angle surgery doesn't work. So yes, absolutely.
Thank you.
So in these cases you performed, Yasmin, post PPVIs, were you able to quit medications in most of the patients? So how do you feel?
Well, in most patients, the case I'm presenting is the best, of course,
Yeah.
but all the rest are
I
probably
have
on
such patients too, yeah.
I have to go back and review the cases, but but the thing is, you're starting out with a pressure of say 32 on full topical. If you bring it down to 15 on combination therapy, this for me is a success, because this is what I see when I do an Ahmed glaucoma implant or a Bervel. In these eyes, eventually they end up using medications for life again. So if you get away with more invasive procedures again, and the patient is accepting that they're likely to go back to meds, I would still choose to do that.
Yeah, exactly. We should discuss definitely this with the patients.
Yeah.
Great case.
Okay. Thank you very much. Thank you, everyone. It's been a pleasure to have all these great speakers today. Thank you for the great discussions and the great cases. And thank you, Dr. Mohammed Lamri, for arranging all this. And I hope to see you all in the World Glaucoma Congress soon this month. And have a lovely evening, everyone.
Thanks.
Thank you.
Bye.
Thank you.
Thank you.
Bye.
See you soon.
Bye.
See you.